Hi, good afternoon, everybody. Well, we're going to try this one more time. This is Mary Foley, and I really want to apologize. I love technology, especially when it works. So somehow or other, we lost phone line and internet connection briefly here in Midtown Manhattan. And so despite all the rumors that things are working just fine in New York, they may not be. Anyway, I appreciate the messages that we got online from friends and participants telling us what was happening. I think we're good to go. And I'm going to move a little more quickly through the introduction. I'm just thrilled to be part of this program and part of the Safe and Common campaign. Let me tell you a little bit about Safe and Common. It's a nonprofit organization uniting healthcare, industry partners, key healthcare associations, thought leaders, and grassroots supporters around the common cause of providing a safer environment for healthcare workers, their patients, and communities. Over time, as we've had conversations in this country and globally, we recognize that there have been significant progress. But we've also heard from students and nurses, housekeepers, patients, and visitors that they still work with exposures. So, what's the unfinished agenda? Where did that title come from, and what has it meant to all of us? As I mentioned, we have been going around in participating in national society and having the privilege of being on the campaign. Some of the messages from our colleagues I want to remind us of about the work that's still to be done. In this dialogue, you've also provided questions at the beginning of the conference, and we're seeking your input even further as we conclude the conference today. We want your ideas about future conversations. We already anticipate an online conference in February, and you'll see that at the end of the program. And actually, at this point, we want to get some opinions from you, and we will go to that shortly. But let me give you the very quick overview of how you can operate the program today and actively participate with us. So we have the tab on the next page, which will show you how to move among the functions on this webinar. So as a participant, you have speaker bios that are available to you, and those are on the blue tab. So I'm going to be brief in my introductions of our friends. Information on our teams of participants. And that will provide you some information on, and certainly on the needlestick injury and injury reduction. And then there's the slide tab, which hopefully you're already doing. And we are using social media today, Facebook and Twitter. We'll have updates and feeds from this program. Last but not least, we want to continue to collect your questions and for you. We may not be able to answer questions we see remaining hour, but we do want to collect and promise to you in the near future that we will synthesize the questions, provide responses to each and every one of them on the Safe and Common website. So stay tuned and keep checking back for that update. So what is the unfinished agenda? The unfinished agenda really means that we've had the opportunity, and what we want to take time to do today is really reflect on where we've been. Where did needlestick injury, what was the origin of the concern, historically what was accomplished, where we are today, reflect on the progress, and perhaps more importantly, reflect on the gaps. And then most importantly, to identify what the future needs are. We're going to ask you some polling questions throughout today's program, and there will be one shortly. But let me just do a quick overview of where we have been. For those of you who work in the field, a lot of these devices will look very familiar. On the far left, you'll see the most conventional and traditional hypodermic, the needle and syringe with an unprotected needle, and we certainly know that those were at the root of many of the early injuries. Over time, we've seen changes in the barrels. We've seen changes in the needles. We've seen a progression through the retractable phase. Hopefully, we're moving into some of the passive phase so that workers don't have to actively activate. And we do know that needleless products are in rapid production, which would eliminate entirely the potential for Sharp's injury. So it's taking that moment just to take a look at and that we thought very important to share with you. Where we've been, and the timeline speaks for itself. It captures very nicely a culmination of work by the Centers for Disease Control. This is actually a very U.S.-oriented image, but I reflect on that because we do know that a lot of the work had begun here in the U.S. and has guided, and now you are guiding us across the globe. So the OSHA requirements are summarized, FDA advisories up to including one just this fall on sutures, and we know certainly the history of state and federal legislation. We are very excited to say that this picture really is a culmination of the activity that was begun across the country by injury advocates, injury prevention advocates. I was thrilled as ANA president to be in the room when President Bill Clinton signed the initial legislation in November of 2000. Joining me in that room is Dr. Janine Jagger, and in the middle of that picture, and she very proudly deserved to be represented there. Someone you can't see kind of hiding in the left-hand side, another leader in this area, Dr. Karen Daly, the current president of the American Nurses Association, and someone who had been personally injured in her work in the emergency department with a needle stick injury and acquired HIV as a result. So we've had a long passage of time. What we'd like to do is ask you now to do your first poll, and it's a very easy one for you. We thought we'd warm you up as the audience. Have Sharp's injuries been eliminated where you work? Now, if you're not in a work environment where healthcare is delivered, you may select not applicable. You may not know the answer, and certainly that might be true. But if you do have a response to that, please take a look now at this poll and plug in on your computer and answer to one of those questions. So what we're showing you now are the results of that poll. We thought it'd be important for you to get really an instantaneous response, and I'm shocked but not surprised.
I consider myself very fortunate in that I entered the field of infection prevention in the late 70s, and I moved to San Francisco in 1982 at a time where HIV was really just being identified. And what it really did was it changed the way we practice infection prevention. It got the attention of healthcare providers, many of whom were very frightened. The public was frightened. There was a lot of very inaccurate, misleading information in the news that got people really nervous about even caring for patients with HIV. But I think when I think about how it changed things is that historically, hepatitis B had been around for a long time, and everybody was just kind of cavalier about hepatitis B. People didn't want to take the vaccine even when it became available. And it was just one of those things that it was like, okay, it's just, part of being a healthcare provider. So when I think about what HIV did to how we practice, is it really revolutionized things. It forced us to think about the risks that healthcare providers put themselves in, every day that they provide care to patients. I think when the first occupationally transmitted case of HIV occurred, it really got people's attention. And I used to think of HIV, if every cloud, they say, has a silver lining, and I think the silver lining to the HIV conditions is that it really forced people to think differently, and it forced people to say, we should be practicing, better infection prevention than we are. So I think that it really did make a big difference. So I was very, very involved from the very beginning with the introduction of Sharps devices that were designed to protect the healthcare provider.
I actually received a needlestick injury in the early days of the HIV epidemic, before we knew what we were dealing with, really. I was involved in it was an emergent situation where we were drawing a blood gas on a patient. We knew that the patient was in trouble, and one of the residents had drawn the blood gas and was handing me the syringe, and drove the needle into the base of my thumb. So at that point in time, the CDC was doing a study, and I had a choice of either receiving prophylaxis or not receiving prophylaxis. So I think I'm patient 066 in the CDC study. I was blessed to have never converted, and at that time, AZT came in a bottle with a skull and crossbones on it, and so I decided that I didn't want to take that drug, and we didn't really know what we were dealing with, and I was wearing gloves, so I've been A-OK, but it's a much different world now than it was in the 80s. So this is an important thing.
As you had an opportunity to see, we heard from infection control nurse Barbara DeBon, a colleague from San Francisco, talk about the early days. I think we could safely say the injury challenges of the 80s and 90s are continuing today, and your poll results certainly confirm that. There's been a reality that we've recognized that a lot of safety devices in use today were actually developed earlier on and were implemented immediately after enaction of the law. Innovation and demand for safer products, in my mind and in the mind of others, perhaps has been stagnant, and that bottom line, injuries continue to occur. So it is now my privilege to introduce the first of our panelists who will speak about other aspects of her work as well. And Dr. Janine Jagger, a key pioneer who's been part of our crusade for over 20 years. She's a professor at the University of Virginia, but most importantly, and known to many of us as the founder and director of the International Healthcare Worker Safety Center at the University of Virginia. Janine, I'm so happy to have you with us today so you can talk about your anniversary event that gave genesis to your consensus statement, and please share your thoughts with us. Thank you.
Thank you, Mary, and it's terrific to be here today, and the list of participants is really impressive, and I'm just so excited that we have people here from different places in the world, and some from Africa and some from the Middle East, etc. So this is really a great opportunity to spread this message. We were really privileged to have this 10-year anniversary event at the University of Virginia celebrating the Needle Stick Safety and Prevention Act, and also it was a time to do a review both of all the progress that we've made and what's left to do going forward. And we had, just a very wide variety of specialists with us, people who've been involved with the history of bringing this issue forward in the U.S., and then we had international colleagues as well to assess this in a more international spectrum. And we also came up with a consensus document as to where we need to go moving forward. And since we do have an international group today, each country is at its own point in the timeline of their progress. Some countries are more advanced, some countries less so. And what we've seen in the U.S. is, first of all, huge progress. When we look back to the beginning of attention to this issue, which really was at the beginning of the AIDS epidemic, the progress that we've made since then is just tremendous, including the hepatitis B vaccine and the treatment of HIV, which has made a tremendous difference for healthcare worker risk, and then the introduction of devices with safety features on them and improved products to protect healthcare workers from blood exposure. And there's been, very heavy focus on that in the U.S., and the medical device manufacturers have made tremendous contributions, and they should be acknowledged. We couldn't have made all of this progress without them. So in the U.S., the law made a huge difference. We had a very dramatic drop in needle stick injuries the year after the law was passed, and we saw that a mandate at the national level was very important and very helpful to us. So that's something to consider in other countries. But the areas in which we've been haven't made as great progress as others is the surgical setting, where the implementation of known safety strategies has not been picked up at the same level as it has in others, and the culture in surgery has something to do with that. Also, the injuries and exposures in non-hospital settings as well, those areas are less likely to be subject to enforcement activities, and they just don't sense the urgency to the degree that hospital settings do. Also, we haven't really maintained the level of involvement that should be encouraged in terms of the involvement of frontline healthcare workers in the selection of safety devices. Their input is really critical. No one other than the healthcare workers who use the devices really has a full spectrum of knowledge of what features will make a difference for them and which ones won't. So we need to continue to press on that issue of healthcare worker involvement. Also, the largest areas of risk have been very well addressed by the medical device manufacturers, but there are gaps in some areas where there are more specialty devices that are still needed for specific kinds of procedures or settings. So we still need to bring that forward to the medical device manufacturers. And we need to continue educating and training the healthcare workers, and we need to also work on training issues during the education of healthcare workers at medical school, nursing schools, et cetera. So we still have a job to do. We have come a long way, and we just need to press forward in an organized fashion to make the next level of progress. Mary, back to you.
Thank you, Janine. You did a wonderful job summarizing that important work of your consensus statement. Reinforces, of course, that there is more work to do. This is a slide I'm showing you that we've used in the Safe and Calming campaign. It reflects the data from Massachusetts, which has a very robust and mandatory reporting of all hospitals in their state. And they're showing the use of standard and safety syringes between 2002 and 2009, and some of the patterns that are apparent here. Certainly hypodermic needles, we've seen increased use of safety. However, there are certainly reports that there are still injuries occurring even in what are classified as safer devices. In fact, several studies have begun to show that in a range of 52 to 75% of safety devices are not activated at all or correctly. So that's kind of a shock and certainly should take us back to the design table perhaps. I think importantly the suture needles are really clearly an example of an inability yet to see large numbers of settings incorporate safety into their products. And as identified in the consensus statement, the surgical area is a very high priority and one that has been very difficult to address their injury reduction. So at this point, we have a poll, I think. No. Oh, we have a video. Sorry. So we're going to go to another video. I think it reinforces what we were saying and what's apparent in the consensus statement. It is a multi-strategy push that we need to have. We need to address the culture in our work environments. We need to address education and training. You'll hear two of our experts, Dr. Robin Gershon and Mr. Tim Gleason, talk about some of those issues, and then you'll hear from me again.
Safety climate. First, it's a little hard to get your hands around because it's almost like a climate. It's very ephemeral in a way. It's almost like the wind. You know, how do you measure this concept? And what it is and how it has been defined is the employees' collective perception of how safe their workplace is. And once you get your hands around that, you can start what we call operationalizing it. And so we say, this is a place where I can trust my employer to keep me safe. I can trust that they're going to do everything they can to make this a safe and healthy workplace for me. And what does that mean? I mean, it's so many things. It's from policies and procedures to actually, as Larry would always say, it's the deed, the word, and the deed. It's not just saying it and having the manual, the infection control manual or the safety manual. It's actually living it, experiencing it, making sure you have the safety equipment you need, not only the best, but that it's available and accessible to you. And it always starts at the top. Although in a few cases, I have seen it, personally I've seen it, when workers from the bottom up say, we want this, we need this, then of course the whole structure can change.
Two of the things I think that we've seen really have been somewhat difficult is we've had great legislation in 2000. I think there was a little bit slow to drive the adoption, and then we had a quick ramp up in adoption, and then I think now we've gotten to a point where ultimately we've hit a ceiling, and I think there's an opportunity to take it up another step, drive innovation, and again, increase the adoption across all facets, not just the acute care setting.
There are quite a few gaps, and I think one of the areas that is an example would be different sizes of patients. And there's still devices that are being put into the market that are just conventional syringes with needles attached to them. And in practice, in reality, we know that if that's a device that's put in the hands of a healthcare worker, then that's what they're going to use. And we really have to make the right thing the easy thing. And doing that means putting devices in the hands of the people that are using them that are not going to be at high risk for causing a sharps injury. So unfortunately, most of the devices that are on the market do require a person to do something different than they might feel is safe or that they feel is natural. When I think about whether or not we've made progress, the answer is yes. We've definitely made progress, but we haven't gone as far as we need to go. There's still many opportunities to provide a safer workplace for the people that.
So you've had the opportunity to hear from folks as they reflect on the type of work that needs to be done in our institutions across the country and across the globe. We also have another opportunity to hear from some frontline experts. I think it's fascinating that at one of our recent conferences with the Association of Healthcare Environment Workers, it's very important for us to consider the entire community of caring and all of those individuals involved in providing a safe and healthy workplace. I think you'll enjoy the story being told by Mark as he shares, and we also know that we've had the opportunity to hear another one of our speakers previously, and you'll be, I think, very touched by her dream.
I've ever done or I've ever experienced when I was working in a hospital conducting surveys is I was walking with the CEO of a hospital, and this particular CEO was commenting on the housekeeping staff. He was really hard on them, complaining about how well they do, complaining about their intelligence, and complaining about all the things that they do in the hospital. And it was wearing on me, actually. So as we was walking down in this one clinical area, I've come across a bio container, and I asked him for his pen. I said, "Let me see your pen there." So I got his pen, stepped on the container, and tossed the pen into the bio bag. Well, the CEO immediately then lunges for the pen. So I grab him and hold him back, and I say, hey, every one of those housekeepers that you were talking about were smart enough to know that that bag would kill them. So everybody could use a little more training, a little more understanding. I mean, here's a guy that was going to go for this bag for an $185 pen.
Well, we need to understand how to apply precautions in a better way. Many times nurses perceive that just being exposed to blood is part of the job. That's just what we have to accept. I think we need better devices to control for the mucocutaneous as well as the percutaneous exposure, along with the education and training and changing the culture in these organizations to where it incorporates the healthcare worker as well as the patient in this entire culture of safety with trust.
My dream of needlesticks. Clearly, we need the manufacturers that take the companies that not only make the devices but make injectables, because these devices have to work together. We certainly need the frontline providers because they're the ones that have the experience. We certainly need leadership because if the leaders and the administrators are not connected to this, then I don't see progress being made as it really needs to. And it really just has to be a collaborative effort. We need to involve our housekeeping members and our engineers and anybody that has anything to do, whether it's a pharmacist. We're going to need a really big role because a lot of people at the table. And if we make decisions in isolation and don't involve the frontline workers, we're making a big mistake.
Well, I think a lot of us share that dream, and three people who are with me today as panelists are certainly some of the dreamers of improved safety. I'm really pleased to introduce three people that have worked tirelessly on these issues for many years. PJ Haylock is our first panelist. She's a registered nurse, currently executive director of the Association for Vascular Access, previous president of the Oncology Nurses Society, and actually a colleague of mine from our previous hospital days in San Francisco. Dr. Janine Jagger, you've heard previously. She spoke to her conference and to the consensus statement, and joined very special guest Gina Puglisi, a very strong advocate for patient and worker safety. She worked tirelessly during the implementation of the needle safety law and is now at Premier Safety Share. And three very expert individuals. Thank you for joining me today. So PJ, you have the first question. And my question to you today is, and particularly since you are the frontline provider on this webinar with me today, what should be done to improve healthcare worker safety for those at high risk of Sharps injuries?
Well, hi, Mary. It's quite wonderful to be here and to work with you on this, and also to be here representing the Association for Vascular Access. Just looking at what the Association for Vascular Access members tell me, I think that there's maybe four major factors. I think one is what Safe and Common is doing, which is increasing the awareness that this is still a major problem, and two, to take an active role in eliminating the complacency, I think, that's out there still. So I think Dr. Jagger mentioned some of the very things that I had thought about, but the first is education. Well, actually, there's four things. There's education, clinical practice realm, management strategies at all levels, and last but not least is creating partnerships or relationships with industry, manufacturing, and research and development. In education, it does kind of go back to the basic and also continuing education. I feel like I'm an older nurse, but it seems to me that somebody must have put the fear in God in us. I've been a nurse for over 40 years, and thank goodness have never experienced a needle stick or Sharps injury personally. although I know many people who have. I think there's also a socialization aspect that goes into the education in terms of accepting or not accepting that this is a risk that everybody has to take to be a healthcare worker. And then the last thing is just practicing these skills, the use of the devices, the procedures, so that the correct way pretty much becomes second nature to clinicians. The other is the clinical practice arena, where we need to set up systems that value and acknowledge the skills of clinical educators, people who are experts in adult education who can share wisdom and practice techniques with clinicians. Competencies, ongoing skills assessment. I know many hospitals that institute skills days to just ensure and update and validate clinicians' competencies across the board, and not just clinicians, but also any healthcare workers that have exposure to sharps and needle stick injuries. Some of the competency skills, at least from the literature that have been identified, is failure to fully activate safety devices that require some kind of active manipulation on the part of the clinician. A really important thing, I think, is team member support in the healthcare setting to give the worker the appropriate time to complete a procedure from beginning to end, and sometimes that even starts with patient assessment, determining whether the patient is capable of cooperating with whatever this procedure is going to be, and clear through completion of the task, including cleanup of any kinds of equipment that are left at the bedside or in the operating room or whatever setting. Particularly home care, I think this is an important area. And the other aspect is management at all levels, reporting, making sure that the climate in the facility is one that is supportive of reporting data so that there is a benchmark in that institution or facility of what is a current level of problem with injuries, so that early recognition can take place and interventions put in place as well. The culture of safety is kind of a mystery in terms of what that means for all institutions, but I know that it's a buzzword recently. But I do think that means support of ongoing education and support for the time required by any processes that involve sharps and needle stick injuries. And the last is, I think that's really important, is for all of us, all clinicians in whatever setting or management level, to do as best we can to create partnerships and relationships with industry, manufacturing, and research and development. This is one thing that I'm really proud of the Association for Vascular Access for doing. It is a multidisciplinary organization that really does support relationships with manufacturers. But I think it also goes back to an institution level where manufacturers, sales reps, continually describe the difficulties they have in getting into institutions to provide continuing education or information with regard to correct use of the devices that they're providing. On the other side of that, clinicians need to have a resource where they can go back to manufacturers and R&D people to identify or share with them information they have about what works and does not work in the clinical setting, flaws in the devices, or places where the device might be made easier or more foolproof to use. So I think those are some of the main things that all of us can work at some level to facilitate in our practice wherever that is. And I know that is, as I said, one of the hallmarks of what we do at AVA. I think with that I can pass it back to you. Thank you.
Thank you, PJ. That was fantastic, very comprehensive and reinforcing of the messages that we've heard even in just today's webinar. So my second question is for Janine Jagger. Janine, You've been well known in the area of data collection and surveillance, and your EpiNet program is an international institution. It's really helped us evaluate our successes and identify the gaps. What do you think has been the benefit of centralized reporting, and where do you think reporting should go in the future?
Thank you, Mary. Well, first of all, I would say that the benefit starts with the standardization of the reporting. The questions that you ask will actually define the shape of the problem that you will later understand. So getting the best set of questions and standardizing on those is the first critical thing. Once you have some standardization, the second question is whether you can network with other hospitals, other institutions, other groups, and even other countries. The benefits of this are numerous and extremely important. First of all, you can get larger numbers. If you can combine data with others, you can build your numbers up, and the larger your numbers, the more refined questioning you can do. When you have a multifaceted problem like, say, needlestick injuries and sharps injuries, and you have so many devices involved, in order to be able to cover the whole spectrum of them, the larger the number, the more complete you can be in focusing on smaller parts of smaller, less frequently used devices and procedures and that kind of thing. So that is, numbers is just a very important part of the issue. But then you can communicate with others. It's a kind of common language. Everybody can be benchmarking on the same basis. So individual institutions can understand their issues in context of the larger whole. Also, in this area, communication with industry is extremely important because this is the evidence base that industry will use to continue to design safer devices. So it gives industry much greater access to data that will be relevant to their product development issues. In addition to that, it allows you to do long-term tracking, and you can much more readily understand what is of benefit, what changes are of benefit, and what changes are not of benefit, or are there new risks that arise over the long term. So in addition to that, the larger numbers that you have, the faster you can learn what these issues are, because if the numbers are small, then it will take you much longer to collect enough cases of that particular problem to be able to see any trend or any message in it. So it really speeds up progress to be able to standardize and centralize. Also, something that has been very important as time has gone on, we've learned more and more by being able to compare with other countries. And that's been a new level of learning, because when you compare your own data to yourself, you don't see the idiosyncrasies. When you compare to another country, then you can see what your idiosyncrasies are and theirs. So that's a process that is very informative, and we all have something to teach someone else. We all have something to learn from someone else. So that's the highest level of learning, when we can compare from one country to another. So there are many, many important benefits of standardized reporting, and those have been it's been really fascinating to see that as it kind of goes around the world. Mary, back to you.
Janine, that was a great response and very instructive for all of us as we work on this. And my last question for our panelists today is, Gina, thank you for joining us again. And how do you suggest we integrate worker and patient safety when we are all working in a financially driven culture?
Yes, in preparing my remarks to answer this question, I talked to a number of infection preventionists and quality and safety and occupational health professionals to get their perspective, including Elise Handelman, formerly of OSHA, and Angela Laramie, who leads the Massachusetts mandated needle stick surveillance program, and as well as Kathy Gosnell from Premier, who's learned a lot from hospitals about implementing devices and some of their preferences on the types of devices and best practices. And we heard from the data that Mary presented that needle sticks are still happening. Our audience tells us this, even with safety devices, and these are preventable. And we saw some data from the Massachusetts program, which is the only active statewide reporting program. And even with a mandatory program for reporting and mandated use of a safety device, unless they have a waiver, they're still seeing injuries. I think we're coming into an era of complacency about these injuries. We know that they're statistically rare events, although compared to other safety issues, but they have very serious consequences. I think we're also seeing less fears about HIV, and it's not perceived as being fatal because of many of these new therapies. We're seeing reduced seroconversions because of the post-exposure prophylaxis, and I think this is drawing some of the attention away that needs to get back onto needle stick prevention. We're also in an era of reduced reimbursement. We've been hearing about this for the 30 years that I've been in practice, but it's really sharpening right now. We have CMS reducing payments for certain hospital-acquired conditions. We're looking at pay-for-performance and value-based purchasing. And so we're always trying to find additional ways, as always, to remove costs from the system, but we don't want to compromise safety. So patient safety right now is getting all the attention, and we need to get worker safety higher up on the radar because many of these issues really are a combination of patient and worker safety, and many of them kind of overlap, and it's a logical connection. I think back injury is one example for worker safety, and it's the name change recently has moved into safe patient handling, and this is really to expand the focus to both the worker and the patient and help prevent patient falls and patient injuries from unsafe handling, as well as the back injuries among our clinicians. Falls is also one of the CMS conditions with reduced reimbursement. Falls with injuries, that is. We're also seeing an overlap in safer injections. There's been lots of attention here. There's been a focus on the dozens of outbreaks of infection, some of them involving over 100 patients with hundreds of 125,000 at least patients being notified of potential exposure, all from clinicians with unsafe injection practices like reuse of single-dose vials and syringes. And this is one of the things that the Safe Injection Practices Coalition, its one and only campaign, has focused on to raise the awareness of the public and the providers on this issue with one needle, one syringe, one time. And now they're trying to integrate worker safety into the educational efforts. So I think we need to focus on where this overlap is in the patient and worker safety. And we heard about the importance of the education and the compliance. And we know that patient safety culture, there's been a lot of research done in this. One of the leaders in this is Robin Gershon in linking patient safety culture to reduce injuries to workers from needle sticks, to patients from harm, adverse events. And to get patient safety culture in an organization, it really has to be the visible support for management. And one of the things that I learned that you have to realize is sometimes workers don't perceive the patient safety as first. We did a study looking at safety attributes of syringes in 25 hospitals, and the number one attribute reported by clinicians was the accuracy of the dose. Could a syringe give an accurate dose? Not reliability of the safety feature. And if we're trying to implement the safety culture in an organization, we really have to get the visible support from the highest level of management. It has to be a priority. And we're seeing a lot of these safety walkarounds for patient safety, and it would be very easy to incorporate some of the worker safety issues, making scripts out for the management team that's walking around to find out what issues are involved with both patient and worker safety, and then to take visible action on this issue. rewarding reporting of these injuries in a non-punitive way, learning from some of the near misses, from some of the surveys that we might do on how these devices are used and potential injuries that have been sustained, learning from the actual injuries that happened so that we can actually incorporate safety into this. And correcting hazards quickly, getting all of the unsafe devices out of and all the standard devices out of the work setting. And I think an important thing in the culture of an organization is to hold staff accountable for using safety devices and appropriate protective practices and barriers, and incorporating that into their performance review, and for physicians as well into the credentialing process. We heard about the OR being a particular area of concern, and this is where department or unit champions, particularly physicians, are really necessary. Giving real-time feedback is also important. And we heard from a number of our panelists about listening to the concerns of the frontline workers, especially where we have gaps in safety devices, like sometimes on the procedure trays. I did want to mention that the CDC workbook design, implementation, and evaluation of the Sharps Injury Prevention Program, which is available in PDF or in a CD-ROM. We have it available from the Premier Safety Institute. It's also available from the CDC. There's a link to it from the Safe and Common website under facts and then resources. It has tools to assess worker safety culture. It has a survey to measure healthcare worker perceptions of Sharp safety culture, and lots of wonderful resources to improve your programs, to tweak them, and to do problem solving. And I'll turn it back over to you, Mary.
Thank you, Gina. That was fantastic. I just want to thank all the panelists. You were really superb, and I think the interaction between all of your comments was just so evident and consistent with our video messaging today. So it is a comprehensive plan to address a difficult and troubling gap in our safety, but we're working on it. And this is the first of our webinar series as an example of continuing to work on it. As I mentioned earlier, we did receive a number of questions from the audience and have continued to receive questions during the course of the program. And we're in the interest of time, because we did start late due to our technology problems, we're going to forego any additional Q&A from the audience right now. Again, we will summarize these questions, we'll provide responses, and they will be posted on the Safe and Common website. And as you know, if you didn't know, this program has been taped and will also be available on the Safe and Common website. So now we ask you for another audience participation poll. We want to know what you consider to be the greatest priority to help eliminate Sharps injuries. We're actually going to ask you to force yourself to answer with just one selection. I think many of us would say all of the above, but I think each of us come from a different perspective. And if you could respond to this now, we'll give you about 3 or 4 seconds, and then I'll ask to have those results portrayed. So we're sending those results to the screen now, and what you can see, strong support for engineering solutions. We've started our conversation with how we have made progress in addressing some of the needle stick injuries and Sharps injuries with some improved devices, and clearly that seems to be an area of additional priority. And I'd say the second one is stronger enforcement and active involvement of the frontline worker. One of the questions that was posed to our group we'll put the answer online, but it really was, isn't it an expectation that the frontline worker be involved in the evaluation and selection of devices? And the answer is yes. So this is very reinforcing, and I appreciate your participation in this poll. Well, at this point, I'm going to start to summarize and move us in preparation for our next webinar, which will be on February 5th. We are gathering from you information about what you would like to see in that webinar. You'll have one more poll to help us with that. But more importantly, I want you to take a look at the call for abstracts. We're actually going to have you submit your ideas and involve you in our presentation on topics that you think would be especially important. I'm certainly very intrigued by the practice area gaps, certainly the consensus statement, for example, the OR and the non-hospital setting. Clearly those workers and their needs need to be addressed, and I think they are high priorities for us to keep talking about with the specialists in those areas, but also the culture of safety, how to balance injury reduction, success stories. You may have some success stories, and everybody is looking for those best practices, and any other ideas that would protect healthcare workers. On the Safe and Common website, there'll be a mechanism for you to submit these abstracts before December 31st and a template for them. They won't be elaborate. It will be a very simple process for you, and we will invite you then, if your abstract is selected, to be part of our participants. So already we're announcing February 5th, 1 o'clock, and we look forward to being with you at that time. So I just want to thank my participants one more time. Before we close, though, in the interest of gathering your thoughts on those next sessions, and February is our next one scheduled, but I anticipate there'll be more. Why don't you take a look at the poll questions and what topic you think would be most beneficial to you in addressing the sharps injuries. I ask you to vote again with your keyboard, mouse, whatever product you're using, and we'll then display those results. So I'll give you about 3 or 4 seconds to do that. Okay, so let's see the results to the poll. We're going to send that to the screen. And very interesting. I think it reinforces the big gap that we know is looming, and that is in the operating room, surgical area. Certainly the culture of safety. Actually, the other categories did very nicely, and each of them get a really strong support. And I think it's consistent with the overall goals of this campaign, which is to keep active on all those fronts: education, culture, device design, and really keep the ball moving. So that's very gratifying. Thank you for your feedback. At this point, we really want you to be sure to take the pledge, if you haven't already, and disseminate that pledge. If you sign up for the pledge with Safe and Common online, you'll get an email that then you can disseminate to your friends and to your colleagues and to your coworkers. And we're using the pledge as a symbol of how widespread the support is for worker safety around needle stick injury reduction. And we're over 10,000 pledges, and those are just folks we've come across at the conferences in this country, and some of our online and social media. We will be providing the answers to the questions that you've submitted both on the Safe and Common website, and it's safeandcommon.org, and also in the social media areas, both Twitter and Facebook, that we use for Safe and Common. What we'd like to conclude with, first of all, my deep thanks to all of you who hung in here with us and participated. Over 400 of you are still online. I thank you so much for that, your dedication to this topic. Certainly we look forward to having more active conversations with you via email, your social media, and look forward to staying in touch with all of you. Many of you, I hope, will join us on February 5th as we continue to discuss in detail some of the areas that remain outstanding. But I wanted to leave and again, to my thanks to the panelists particularly. Thank you so much, PJ, Gina, and Janine, for your commitment to the work and your excellent information that you shared with us. I'm inspired by our future generations of healthcare workers. The National Student Nurses Association program in April gave us an opportunity to record some video clips that we're going to leave this program with. It's inspiring and challenging because they want us to prevent injuries to them. They understand it, they get it, and they're challenging us to step up and do it. So let's finish this agenda. Let's do it together. And again, thank you so much for sharing this time with us. And we look forward to...
If they can put a man on the moon, then they can eliminate needle sticks.